Hello, and welcome to our presentation on exploring the role and feasibility of natural language processing techniques to improve mental health services in Africa. We are a team from Makerere University, Butabika National Hospital, Mirembe Mental Health Hospital in Tanzania, and the Uganda Cancer Institute. I will allow the members to introduce themselves briefly, starting with Joyce.
Yeah, thank you. My name is Joyce Nakatumba-Nabende. I'm a senior lecturer of computer science at Makerere University, and I am the head of the Makerere Artificial Intelligence Research Lab at Makerere University.
Thank you. I'm Juliet Nakku. I'm a senior consultant psychiatrist and executive director for a large national referral mental hospital. I'm also the past president of the African Association of Psychiatrists and the representative for the World Psychiatric Association for East and Southern Africa.
My name is Sadiki Mandari, psychiatrist, head of mental health section, and also acting director of medical services at Mirembe National Mental Health Hospital at Dodoma, Tanzania.
And my name is Johnblack Kabukye. I am a medical doctor at the Uganda Cancer Institute. I'm also a postdoctoral researcher in health informatics and digital health at Stockholm University in Sweden. We also have other team members who could not join in this presentation, including persons with lived experience and other persons working in artificial intelligence and computer science, as well as psychiatry and mental health care.
For introduction, there's a large mental health burden in Africa. An estimated 10.9% of the population are affected by mental disorders. Due to under-resourcing, stigma, and poor infrastructure, the treatment gap is large. Up to 75 to 90% of people with mental health issues on the continent do not receive the care they need. There is paucity of data on both the more common conditions, such as anxiety and depression, and the severer ones, such as psychosis. There is a human resources for mental health challenge. Mental health workers in Africa are estimated to be 1.6 per 100,000 compared to the global median of 13 per 100,000 population. In selected countries on the African continent, the numbers are extremely low, lower than the average for Africa. In Uganda, for example, for a population of 46 million people, the number of psychiatrists per 100,000 population is only 0.082, and that applies the rest of the countries. The more reason, therefore, that we should use other means.
So given the background around mental health in Africa, we see that there's a potential of the use of mobile phones. As of 2023, we see that there's a smartphone adoption, which stands at 42% in Africa, according to a GSMA report. But this leaves out the rest of the population with either no access to smartphones or access to low-cost feature phones. On the other hand, we see that Africa is home to over 2,000 languages, and many of them prefer to communicate in their local languages. For example, populations in Uganda or in East Africa, where many of the languages that they speak are either Luganda or Swahili. However, most of the mental health services that are available right now in hospitals or even over the internet are provided in English or other official languages. And this makes it very difficult for patients with low literacy or those in rural areas without access to internet or mobile phones to access these mental health services. There are innovations in natural language processing, automatic speech recognition systems, and artificial intelligence that can bridge the language and communication gaps, therefore making mental health services more accessible to rural populations. In the way of doing this, we can be able to automate and provide mental health services to populations, for example, the use of interactive voice response systems, which we shall provide further details on in the next slides. AI and particularly ASR systems have the ability to understand speech and text in local African languages.
Now I'll talk about our current solutions to the above-mentioned challenges in mental health care, and that is mental health telephone services. We have set up one in Uganda at the Butabika National Mental Hospital, which has been running for a little over 2 years. This service is heavily reliant on automation using a self-service phone or interactive voice response, in which pre-recorded mental health messages are delivered to patients via telephone. People choose on their phones a corresponding number and they can listen to a pre-recorded message. We also have an option for a person to speak to an individual when they have a very specific question that we couldn't anticipate in the pre-recorded messages. The agents that answer calls are health workers, but also persons with lived experience. This service is available 24/7 because of the automation, and it's also toll-free, so the billing is reversed. The hospital pays so that the callers don't face financial challenges. We have multiple channels, so we don't get a busy signal. Messages are now available in English and Luganda, but we hope to add more given the many languages that are spoken in Uganda. This is the IVR tree showing the logic. A person calls in from any telephone and they are allowed to, or they are asked to choose a language. We give them some disclaimer information, and then they are presented with a menu from which they can choose a topic. For example, what causes mental illnesses, or how a mental illness is assessed and treated, or referral process. Or they can go into a specific mental illness like epilepsy or schizophrenia or mood disorders, and then being able to speak to a person. Details of this can be found in the published work, which is also shown here. We have done surveys of the user experience, and we have done quality control of the calls. In 18 months since go live, we have more than 5,000 calls, and many people are returning. As you can see, we have fewer unique numbers. But we also see the demographics of the users. So for example, 18% of the callers are patients, while a big majority are caregivers, and that helps us to know the people we're targeting and how we can design the messages. We also see from the IVR the topics that people are looking out for. Most of it is about understanding the mental health conditions, what causes it, signs and symptoms, but also see people looking for information about mood disorders or psychosis, and practical information. We've gotten lots of positive feedback, but I wanted to highlight the limitation in this qualitative comment, where someone mentioned that the length of time it takes to get to speak to a responder or a call agent is too long, and it should be the first option. Of course, if you don't have human resource, that is going to be an issue, but we hope that we can automate with AI and improve user experience. We have a toll-free number, and it's a 0800 number. And when you call in, I'm putting it on loudspeaker. Please choose your preferred language. For English, press 1. For the English route. For English, press 1. This service will provide you with correct information and advice about mental health and mental illness. For information on common mental conditions and common conditions in children, press 2. So I'll choose 2 here to learn about the mental conditions. There are different types of mental disorders that you may commonly see in the community. There are those that affect your mood, such as depression and mania. Others, such as psychosis, affect your experience of reality. Okay, now I'll also do a call where I try to speak to a person. And again, here to do quickly, I'll go through English. And then I choose option 9, which is the option to speak to a person. And then you see that when I choose option 9, we have multiple agents. Some of them are here, some of them are in their homes, some of them are on the wards, but all their phones will ring.
Hello?
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 My name is Johnblack. We're just doing a demo.
I'm called Yaria Amona.
Thank you so much, Yaria.
I was diagnosed with schizophrenia in 2017, and a patient in this hospital. I have been on medication ever since. I'm thankful that I have not relapsed. I haven't been admitted again. So I work here at the call center as a peer support worker responder. I receive calls and also I call back voicemails.
When they are discharged, we take them back into the community, and it is patients from the community that do call to know about the services of Tabika, about medication refills, general services of the hospital, like the charges of different wards, like on private wards. People want to know how much is charged. People want to know the time when the psychiatrists and other professionals are available. When I compare a text or website to the call center is better. With a website, you might find some people do not access such services of using a website. Those ones that are from up country, they might not be able to access such services. But when it is a call center, people have at least phones. even if it is this cheapest, but at least they can call and they get the information.
With regard to Mirembe National Mental Health Hospital telephone service pilot, we had 1 month pilot using one phone number that was answered by the psychiatrist for 2 hours every afternoon. And the service utilization was high, but discontinued due to human resource challenges. And we are hoping this project, we can learn from the Uganda experience and obtain and test the IVR system and AI model using Swahili language.
At the Makerere AI Lab, we have previously carried out work in building automatic speech recognition models for African languages. For example, we have built models for languages like Luganda, Swahili, and Lingala with good word error rates, as you can see the curve on my right. So we've had good word error and character error rates. For example, for a model like Kiswahili, we have a word error rate of less than 10%, which implies that we have less errors as the model is doing the transcriptions from the speech recordings. This work that we have done has also been documented in a number of publications, as we have shown, and we will build on this ASR model work that we have done previously for this project. We're going to show you a video clip where we show you some preliminary testing of the ASR models on a mental health recording.
We've developed a simple demonstration for the ASR models that we've developed. We fine-tuned a WAV to VEC BAT 2.0 model on Luganda specific data. I'll just now select one of the example samples that you will be able to listen to and follow along on what the model has transcribed.
abasawo bafe abakugu ne tukwekebejja bulungi obuzibu obwo bwe buba nga bulwadde bwa mutwe ne tukuwandiikira eddagala ne tukunnyonnyola.
It was able to recognize certain health-related specific words, because we can clearly see that there will be a benefit and there is opportunity in fine-tuning for downstream tasks using this model to make it better at picking up and identifying and transcribing mental health words.
The main objective of our project is to explore how natural language processing and automatic speech recognition technologies can improve mental health services in Africa, particularly in Uganda and Tanzania. So on the objective of the ASR and AI model development, we will build on previously collected data sets in English with a bias on Ugandan accents, and also based on Luganda data sets that have previously been collected from Botabika. We will also eventually build out Swahili models through prospective data collection from Mirembe National Mental Health Hospital. So this is important for us, such that we can have ASR models that are tested across 2 African languages. Based on the curated data sets, we'll explore several approaches. The first approach will be to build out Luganda, English, and Swahili speech to text models that will generate mental health transcripts. And these transcripts are valuable because they can be used for aspects such as topic modeling, to study the prevalence and presentations of different mental health conditions like depression, anxiety, and psychosis. The second approach that we shall take will be to build out speaker diarization ASR models. And the whole process here will be for us to look at the call transcripts and then assign timestamps and corresponding speaker labels to audio tracks to enable us understand aspects such as turn-taking in conversations and back-channeling, understanding when the filler pause is coming to enable people to talk, because this is important for us to be able to understand and rate the quality of the conversations that are taking place. And then the final approach that we shall take will be around keyword spotting, which will focus on detecting specific keywords and phrases from audio recordings rather than relying on full transcripts that I mentioned will be our first approach. With keyword spotting, we identify these mental keywords quickly from the call recording conversations, and we're able to do analysis of conversations really across the data that's coming in, but also trying to understand how this relates to the IVR tree, and we can be able to build out AI models. Based on the keyword spotter, we build AI models that can optimize the pathways of the IVR tree based on these identified keywords.
So in addition and parallel to developing the models and checking if they're performing well, we also need to test them from the perspective of the stakeholders, that is the patients that are using these technologies, the health workers that are also affected, and the caregivers. So we will investigate stakeholders' attitudes and opinions and thoughts about these AI, NLP, ASR models, or digital health in general, in provision of mental health care. We want to know their fears, their worries, if they trust these services, and if they have any ideas on how to best deploy them. So we'll hold focus discussions with those stakeholders, and we'll investigate these in a qualitative way. We will also hold testing workshops when we have developed the services. We have modified the call centers and added these technologies to see if people are able to actually use them and if they find any usability challenges. We will also assess the performance clinically, and this will involve manually comparing the model to a human. So, for example, when there is a telephone call that has been recorded, we'll ask a human or a set of humans, including people with lived experience and clinicians, to classify that call. Let's say someone has called in and has talked about how they are not sleeping, how they are in a low mood, maybe they have suicidal ideation. Maybe a human will classify that as depression. And we'll see if the model can also be able to classify that. And when we are able to do this, then we can get a sense of what are the common conditions, what are the common symptoms people are calling about. We can build dashboards to visualize this in an automated way as opposed to what we do now of manually doing it. And we can also be able to keep track of the changes in the prevalence of different types of mental health conditions. The second assessment is we want to see if the models can help in navigating the IVR and finding the information using voice commands. So that requires that the ASR models can recognize the speech, they can pick up the keywords that people are asking about, and they can help in navigating the content. This is similar to what you would call retrieval augmented generation in the large language models domain. So for example, we now have many people asking about the cost of the services of mental health. And this has been answered many times by an individual. And we can now train a model to reuse the answer that have been given and provide an answer to a person. And this can be deployed, let's say, in a chatbot. The other thing is using models to assess the quality of the conversation. When patients call into the service, we want to see how the conversations went. And we have been holding monthly meetings to assess this. But if we can do this automatically, that will save us a lot. For example, we want to see if there was good turn taking. We know that therapeutic alliance can be indicated by the turn taking. If there is back channeling, is the receiver on the other side encouraging the caller to speak? They are important indicators of the quality of the conversation, and we want to see if the models can pick these up and can, in a way, rate the calls. Of course, we shall compare this with independent assessment or ratings by the user. There is also scales, different scales that have been used to assess quality of conversations. For example, the AQTT, or Assessment of Quality in Telephone Triage, the TISS, Telephone Nursing Interaction Scale or Satisfaction Scale, and the Emotional Content and Cooperation Score, ECCS, and the Verona coding. And we want to assess this and see if the models can also apply these scales onto the conversations. All of this is intended to assess and improve the quality of the telephone services. Moving on ethics, we are following strict research ethics principles because this is a very sensitive topic. This is clinical care, and more, it is mental health care. So we are getting all our team members trained on good clinical practice and human subject protection. So far obtained approval, and we will renew approval. And then for Tanzania, we'll get new approval from the research and ethics committees. We have participants provide consent. This is written for those that are coming in the workshops and in the focus discussions. And then for those where we're going to do surveys of the callers, we'll do it telephonically. And of course, the callers are informed when they're calling into the system that the calls are being recorded for quality control or for this research purpose. And the research team is very careful to not include identifying information in the transcription, so the recordings will be anonymized. Then also there will be a lot of stakeholder engagement and dissemination of the findings, like this picture you see where we've been having different participants involved. We have these research meetings, we have these quality control workshops that we hold. We even have a WhatsApp group where we can discuss what's going on and share with the rest of the hospital community. But we plan to hold dissemination workshops with policymakers in Uganda and in Tanzania, and then definitely conference presentations and scientific manuscripts. We plan at least 4 on the different aspects, the performance of the models, so the more technical aspects, but also the clinical evaluations. And here is a slide that shows different methods of us disseminating to different stakeholders, especially via social media, but also different stickers and popular science publications. And we'll continue to do these same dissemination and engagement activities.